All right, let's talk about cardiac dysrhythmias. And I don't know about you, so I did 2 residencies. I did internal medicine and emergency medicine. God knows why. Well, actually I know why, but I did 5 years of training. And even at the end of 5 years of training, I find EKGs still a little bit daunting. There's so much at stake, there's so many subtle things that can be there, and the reality is we have to be good at reading them, and there's certain things we can't miss, but overall you're probably better at this than you think you are, and it's not as scary as you think. We do have a boot camp that we did specifically, a sort of 4-hour course on EKG interpretation that's part of the advanced boot camp course, though, because we all know that we have some anxiety when it comes to EKGs, and we know the stakes are high in being able to interpret them. So what we're going to focus on our half hour now isn't everything that has to do with an EKG. We're going to basically focus on dysrhythmia interpretation, how to figure out dysrhythmias and what to do about them. So in a half an hour, that's what we're going to focus on. So let's get launching into this. I mentioned yesterday, when we talked about chest x-rays, to have some sort of organized approach to looking at a chest x-ray. It's a very similar thing with EKGs, and I am sure every single one of you in this room had some sort of system you learned to do EKG interpretation. I use the Dubin Rapid Interpretation of EKG book. It's still awesome. It's in its 6th edition now. It's been around forever. Super simple, super straightforward, super easy to reproduce, but there are lots of versions out there. So you can access, just Google it. You'll find all kinds of things online on EKG interpretation that'll help you. And I tell you, one of the things about EKG interpretation, and here's one system. The mnemonic here is ARVR PQRST. Just tells you all the things to look at, in particular, by the way, age, because we know that EKGs in younger kids are very different than EKGs in adults, or can be. The reality is you need to have this system approach that you have to looking at EKGs. And the other thing I recommend to get you more comfortable with EKGs is just stroll around your emergency department, because we know that EKGs are done, most people with chest pain have to have one within 10 minutes of hitting the ER. Those of us that work in emergency departments are constantly getting handed EKGs to, look at this, make sure it's on a STEMI. Constantly. The amount of pink paper we go through is ridiculous. Those EKGs often just get thrown on countertops for a while until somebody cleans them all up. Make it a habit to just pick them up and take a glance. So that's what I walk around the ER and I pick them up. It's like, wow, that's a cool EKG. Oh, that one's interesting. Oh, look, first ring block. Oh, look, this person has Wenke block. Look at them over and over and over again, because basically getting practiced at it will make you familiar and comfortable with EKG. So grab those things that are sitting around on the counter. And here's one mnemonic for you that basically just goes through all the parts that you need to look at. But the reality is just get in the habit of whatever works for you, but the same thing every time. So you're looking at all the bits and pieces. You don't look at just the one thing that looks really abnormal. We know that the EKG, all those little pink boxes mean something. We know that there's the duration is sort of on the sort of horizontal axis, the amplitude is on the vertical axis, and we know that one box is the little five little boxes is one box. So basically that's 0.04 seconds for a horizontal box. You can figure all that out, and it's actually all on the EKG. They tell you it there. But you have to be able to know what the normal sort of look of an EKG of a complex is. So we know that the P comes first, and then the QRS does its thing, and then we have the T wave that follows. And those can get messed up all different kinds of ways. The intervals are important. And I'll tell you one of the, so we call it the orthopedic interpretation of an EKG, where they fold it over and they just read the top. So they just read the words at the top and fold it over and not look at the squiggles on the bottom. They joke about it at our own institution. It's like, yeah, that's our ortho interpretation, what it says on there. I will tell you, don't fall into the habit of letting the EKG interpretation tell you what's wrong, because I am flabbergasted, despite how good most of these algorithms are, what they miss. When you use your eyeballs in your brain, you will find that they're calling something VTAC that you can see P waves in. It's wrong. So use your eyeballs and don't use the words at the top. However, what at the top is very reliable and better than you are the intervals. So look at the P, lists all your intervals, your PR interval, your P, the whole thing, the PR, the QT, all those intervals are up there. Look at that. It's better at that than you are. So that's where I look on the top. So the ortho part of the interpretation, I go read the intervals, and then I go down and I look at the EKG itself. And you should make a habit of looking at all of the EKG yourself. When it comes to dysrhythmias, if we sort of start at the top, we start at the atria, because we know that's where your beats are starting. They start up at the atria, at your SA node. The SA node talks to the AV node, so that interval, that's the PR interval, when they talk to each other, if that discussion gets prolonged, that's first degree AV block. And that basically is where more than those 5 little boxes. If it's longer than that, that's first degree AV block. This is basically usually a nothing. It's usually either, if it's in a young person, it's often a very in shape young person. If it's in an older person, it's just getting older. Basically, I think of it as a relationship starting to go a little bit bad. You know, the P wave says to the QRS, you know, hey, or to the AV node, the SA node, hey, you know, make a beat. And it just takes a little while to hear it. And it's like, oh, okay, yeah, okay, I'll do that. Hang, I'll just get 1 sec, I'll get right on that. So it takes a little longer to get sort of transmitted. So that's first degree block. Rarely, if ever, is it anything in isolation you need to do anything about except note it, just mention it. Again, young people, usually healthy. Older people, kind of just a part of aging. It's when it gets a little worse, though. So you end up basically with, it takes longer and longer and longer to respond. This is, again, the relationship's getting a little bit worse. The P wave is talking to the QRS and is basically saying, wait, I'll get to it later, I'll get to it later, I'll get to it later, and then they just don't get to it at all. Okay, this is the I'll take out the trash, I'm not taking it out today. That's basically the interaction. That's basically Wenckebach. So the PR gets longer and longer and longer, and eventually the P wave sends out a signal, and the QRS says, not answering. I'm just not answering. That is actually usually not a scary rhythm, but it should get your attention. Sometimes people have that when they're young and healthy. Sometimes it's because of a medication that they're on. Usually in most settings it's not concerning. The sicker the person, the more you're worried about something like ischemic heart disease, the more you should pay attention to that maybe being something you need to pay attention to now. But the reality is most of the time that's not a serious dysrhythmia. That's something we just kind of go, wow, kind of cool. We'll watch that and see what happens. If that communication gets worse, though, they can actually go to second degree block type 2. And this is basically, the communication is fine until suddenly it's not. So the PR intervals are the same, it beats just fine, and then all of a sudden, out of nowhere, the P wave just tries to communicate to the QRS and nothing happens. It drops a beat. So my PR intervals are the same, and all of a sudden it just doesn't respond anymore. It's not, now that is scarier. It still can be not a go crazy thing, but it's worth talking to cardiology about, and in the setting of especially certain kinds of MIs, you'll hear about them later, that you may end up needing to call cardiology about these as well, because what can, oh, by the way, the intervals will help you determine which is which. So the PRs get longer in Wenckebach, and then eventually it resets itself. The RR intervals, basically the PR intervals in second degree block type 2 stay the same, and then the beat gets dropped. So that it's scarier. Basically, it's just not listening at all intermittently, and that's scary. Not just preparing itself to do so, like type 1, type 2, it just drops a beat. Third degree heart block should get everyone's attention. This is basically the P wave and the QRS are absolutely not talking to each other at all. They are just doing their own thing. You're going to find that the P waves, when they're in their own native state, are at your usual sort of sinus rhythm rate. So it's usually 60 to 100. So the P waves are marching along at that. And then the QRS, when it's on its own, tends to sit at about 60. So you'll notice that the P waves are going marching right through at 60 to 100, and the QRSs are basically on their own rhythm, usually slower. That is almost always abnormal. Now, people can walk around with chronic third-degree heart block. That is not common, and especially in the setting of what we see in the ER. Somebody's been syncopal, somebody's having chest pain, somebody's short of breath. That is a rhythm you need to talk to somebody about. Get cardiology on the phone, get those transvenous pacemaker paddles on somebody, or transcutaneous pacer paddles on. They may want to put a pacemaker in this person. So in the acute setting, assume it is new and assume it is bad. So if you wanted to summarize these initial heart blocks, first degree heart block is just the PR is longer. Second degree heart block is the PR gets longer and longer and longer, is dropped in Wenckebach, or is the same, and then no beat happens after the P wave in type 2, Mobitz type 2. Third degree, there's no relationship whatsoever. And if you're smart, if you really look at that second one from the bottom on here, that's second degree heart block 2 to 1. Okay, so this is basically, okay, it is, but that could either be a Wenckebach with basically a 2 to 1 conduction, or that could be Mobitz type 2. I can't tell based on that EKG, and that is absolutely accurate. You can't tell, no cardiologist can tell when the rate is that, where it basically is a 2 to 1 Wenckebach, or it's just every other beat is being completely dropped in a type 2. This is that you can't tell the difference, and that's actually spot on right. You can't tell the difference with that EKG, which is which. Now, if you go back to the atrium, that's the blocks, the atrium talking to the ventricle, and that's where the conversation's going bad. Let's go back, though, and have the atrium have some just extra beats. This is above the AV node, somewhere out there in your atrium. There's a spot that goes a little crazy. You just end up with a premature contraction. So you have the AV node says, I need to just contract one more time, or you have a PAC out there that just sets off. You're probably having them now. If you went out and partied last night, didn't get enough sleep, drank a little too much, you might be having some PACs right now. People feel them. Okay, they don't always, but people can feel them, and they may come in saying I'm having palpitations, but basically the EKG is not alarming. What you'll find is you'll see that premature beat, and then there's a pause where the QRS says, whew, wow, that was out of the blue. I didn't expect to have to do that early, but you told me to, so I did. It waits a second, and then it goes back to its normal rhythm. PACs are usually benign. There's usually really nothing to be worried about, and sometimes they're wide if they're aberrantly conducted, the QRSs, but most of the time it's not. It's just a premature narrow beat with a P wave in front of it that's actually triggering it to happen. Now the SVTs, technically, anything that is faster than 100 beats a minute and originates from above the ventricle, supraventricular, is an SVT. Technically, sinus tachycardia is an SVT. AFib with RVR is an SVT. Atrial flutter with a rapid rate is an SVT. But when we're going to talk about SVTs for the next couple of slides, we're going to talk about the one we all love, which is that reentrant kind of circus rhythm SVT where things just go crazy and they come in with a rapid, narrow, complex rhythm. These are the fun ones, right? These are the healthy young people. You get the call from triage where they say, got a guy out here with a heart rate of 220, he's 22 years old, he's having palpitations, the EKG shows a narrow, complex rhythm that's super fast, we're bringing him back. It's like, yes! You know you're going to make them better. They're going to walk out just fine. Usually it's like no biggie for these people. It's wonderful. It is regular. It is narrow. And it can be fast. It's usually in the 170 to 180 range. It can actually be faster. It can be up to 200, 220 in little kids. It can be even faster. So this we can fix with a whole range of things that we can do. Anything from adenosine to vagal maneuvers to the fancy schmancy revert and all of its sort of iterations. The key here, though, is sometimes that SVT isn't narrow. Sometimes that SVT is wide. So what they're going to call you from out front is say, we got a 22-year-old guy out here, but you know he's in a rapid rate at 180 and it's wide. Well, now you're going to have to figure out what's what. The younger the person, the less likely it's a bad rhythm. The older the person, the sicker the person, it's more likely a concerning rhythm. And often we can't tell the difference between VT and SVT with aberrancy. Don't worry about it. If the person is unstable, you're going to shock them anyway. That's easy. Whichever it is, I don't care which one it is. Whichever one it is, I'm going to shock them anyway. If the person is stable, I have time to regroup and think about it. I don't have to go charging ahead with any kind of medicine. If they're fine, they're just having some palpitations, but they're not having lots of chest pain, they're not short of breath, I have time to think about it. I can go back and look at those old EKGs and see if I see a delta wave that tells me, whoa, this is a WPW person. Wow, glad I looked at that old EKG. Or go look in the chart and say, wow, this person's had VTAC episodes before. This one must be VTAC. Take your time. Don't freak out. Take a deep breath, step away. If they're really sick, we're going to address it and fix it, usually cardioversion if they're really sick. Otherwise, you're just going to take your time. It's hard to tell the difference. And one of the things about the emergency department is it is really better when it comes to a wide, complex, regular tachycardia to assume the worst. Because you won't do harm in treating the worst. We'll talk about VTAC in a little while. But you might do harm if you assume it's like an SVT and you treat that like an SVT. We'll talk about that in a minute. So the take home here is wide, complex, regular tachycardia. Don't get scared. Take a step back. If they're stable, you have plenty of time to think about it. If they're unstable, you're going to address it, and you're going to usually address it with cardioversion. So it's not as scary as it sounds. When somebody hands you one of those EKGs, go to the bedside, and if the person's doing Sudoku puzzles on their phone, you have plenty of time to figure out what's what. If they're short of breath and sweaty, you know what to do. So if it's just SVT, though, it's narrow complex, it's that 22-year-old that's sitting in the bed with the eyes bugging out a little bit, but saying, just palpitations, just palpitations. What you do with that person, if they get worse, he says, oh my gosh, I have crushing chest pain and their blood pressure drops, shock them. And what I recommend you do, honestly, is if you have time, do some sedation or at least give something that might have retro amnesia like Versed or something, midazolam. But the reality is you often don't have time. You're cardioverting because they're sick. Use a higher joule, use the 100 joule synchronized cardioversion. Just go once. You don't want to do this twice. We did this to an older gal that was in our ER a couple years ago, and we basically came up to her, and she was not doing well at all, really diaphoretic, having low blood pressure, scary, and it was an SVT, it was scary stuff. But we basically cardioverted her. We just basically put the paddles on and said, I'm sorry, just hang on a second, and shocked her to 100 joules. And this little tiny lady, little frail, adorable, perfect, like your grandmother, perfect person, like crochet kind of person, basically sat up and said, well, shit. She said, that'll wake you up in the morning. I was like, I'm so sorry. But she was very unstable. We just didn't have time. That's okay. And I didn't want to do that twice to her, so we're just going to get it over with. And it works. 100 joules in an SVT absolutely works. But if it's a stable guy, he's hanging out, he's just playing Sudoku puzzles, he's like hanging out playing on his phone, you have a lot of options here. Now you can try the Valsalva, right? We're all taught to do the Valsalva. Tell the person to take a deep breath and bear down. People have no idea how to do that. They do the weirdest stuff. I wish I could take videos of their faces, right? They go, they're doing nothing in here. I don't know what they're doing, but they're not doing a Valsalva. So you want to do something else. And so if you haven't heard of the Revert, it's been around for about 5 years now, I recommend looking up the Revert method. It's a modified Valsalva, and you basically have them blow into a syringe. And if you do it yourself, I use a 3cc syringe, but use whatever. Just pull out the little plunger if you can, and have them blow into the syringe. It's like blowing up a balloon. That's a Valsalva. Right, that's a Valsalva. You're like pushing really hard, try to blow something up like a balloon. This is blowing through a syringe. And you take them from a semi-recumbent position, and while they're blowing, you basically flip them over, head down, legs up. It is my personal success rate. Initially, I wasn't so impressed, but boy, I'll tell you, I don't know if I just got better at it or if I just finally hit the odds and it's working, but it's pretty cool. And there's actually another sort of tweaky version of this that's been out there since. So try the Valsalva, that's fine, have them bear down. Try this thing, pretty cool. Sometimes this will work. I don't recommend routinely cardiac carotid sinus massage. You can do that in little kids. I wouldn't recommend it so much in an adult. And we know little kids, you can put ice on their face. Warn the parents first. I'm just not smothering your child, but ice will often cardiovert them. But these are ways to do it short of medication. We know, though, that you can actually treat them with meds. So adenosine is what we usually use. Adenosine's actually been around now for, gosh, almost 30 years, almost 30. We didn't have adenosine before. We used verapamil before all the time, and verapamil works just fine. Only downside to verapamil, it's kind of back in favor now, but it can cause some hypotension, so just be aware. Adenosine doesn't, but what adenosine does is kills your patient for about 8 seconds. It basically puts them into cardiac arrest. It's one of and people will tell you, some people will come in who have recurrent SVT and they'll say, don't you dare ever give me that medicine again. I don't want it. Warn them when you give somebody adenosine that they're gonna feel really weird and they may feel their heart stop for a second. Warn them about this because it definitely happens. And I'll tell you, adenosine works. It works great. So go ahead and use it, but warn them of what's going to happen. The first time I ever used adenosine it was the very first dose I ever gave when it very first came out. We used to use 12 milligrams to start. That was the initial recommendation. And we all gathered around the bed because it was the first time anybody had ever used it in the ER. And the nurses wouldn't push it back then. They wanted the docs to. So I pushed the drug. It went in. We were a young, healthy person. We all watched the monitor. It did what they do, right? They do that flatline thing. It's like, okay, cool. Except it kept going, and it kept going, and went for 22 seconds. 22 seconds of flatline. Oh my God, see this gray? That's where it came from. And everyone was like looking at me like, is this supposed to happen? And I'll tell you, being an attending in the ER, 90% of it is show. It was like, oh yes, this is described by me today because it's happening. It's, oh my God, it works. But we start now with 6 milligrams. Sometimes you're going to get handed this EKG, right? It's wide, complex. It's like, what is this? So this one, you may not be able to tell the difference between VTAC and SVT. This turned out to be an SVT. But again, if you don't know and they're stable, you got time. Go look stuff up. Check it out. Now, another SVT equivalent is AFib, A-Flutter. Okay, this is, in fact, I will tell you, Las Vegas is probably the capital of holiday heart. People who drink too much, party too much, play too much, don't get any sleep. And they basically have AFib or A-Flutter that's just part of what we call holiday heart. It reverts itself back. Lots of causes of AFib, A-Flutter, a jillion of them. Some of it's just aging, sometimes it's thyroid disease, like we talked about yesterday, sometimes it's drinking too much, sometimes it's a drug toxicity. PEs can do it, heart attacks can do it. I will tell you the thing about this. Every new AFib that comes into you doesn't need a gajillion dollar workup for all of these things. And you just use your clinical judgment. If it's somebody who's been playing in Vegas all weekend and they're otherwise young and healthy, it's probably holiday heart. They're going to be fine. But do due diligence as far as your differential diagnosis. Flutter is usually seen in those bingers. It's usually seen in the party-hardy person. And flutter is an inherently unstable rhythm. Your atria don't like to flutter at 300 beats a minute. They don't like it. So they don't stay there. You usually, if it's just somebody who's like a holiday heart person, revert back to normal sinus rhythm. It can degenerate into atrial fib, where the atria goes, forget it, 300 beats a minute is too fast for me. I'm just gonna like jiggle out on this thing because I'm tired. So atrial flutter is something, this is where you see that sawtooth baseline. It's the atrium at 300 beats a minute. And your ventricle doesn't usually go 300 beats a minute. It can't. It's too fast. So it will say, I'll take every other one or every third one. So your rate, your ventricular rate in atrial flutter is always a divisor of 300. If it's a 2-to-1 block, it's at 150. If it's a 3-to-1 block, it's at 100. If it's a 4-to-1 block, it's at 75. And so if you see a monitor that sits there at 150, spot on, looks like sinus tach at 150, it doesn't budge. It doesn't move. It's 150 all the time. Deep breathing doesn't change it. Fluids don't change it. It's probably flutter at a 2-to-1. So that blocking is kind of a way to help you determine what's what, and that sawtooth baseline is what we see with atrial flutter. You usually don't require any treatment for atrial flutter, none whatsoever. Usually reverts by itself. If they're unstable, again, unstable people with dysrhythmias, we cardivert. So you're just gonna go ahead and cardivert. And if they're stable and you think you need to use a drug, there's a whole list of them, but honestly, I cannot remember the last time I treated a case of A-flutter per se. You know, it usually goes back, as long as they're stable, you just hang out, it usually basically reverts itself to something. It'll degenerate to AFib or it'll revert to sinus rhythm. We see so much AFib, it is ridiculous. We see so much AFib. It's irregularly irregular. That is your key, irregularly irregular. It's not the only thing that does that, but it is an irregularly irregular rhythm. And the problem we have with AFib isn't AFib itself per se. That's a chronic problem. That's a sort of anticoagulation, your life is different problem. For us in the ER, is there a rhythm issue right now, rate issue right now that's the problem? Are they going too fast? Or is this brand new and something I need to worry about? Is this going with that PE? Is there something I need to be worrying about with AFib? The causes are the long list of causes I mentioned the other day, and when it's acute, they flipped into it today and they weren't in it before. It may be something like I'm studying, this happened to one of my nieces, studying for her tests, her midterms, and she drank way too much coffee and monster drinks, and I mean, she caffeinated herself too. AFib, basically threw herself into a transient AFib. So that it can be something that's acute that triggers it. I'll tell you one thing, if there's one thing you walk out of this half hour together with that I think is a vitally important concept, if someone is in chronic AFib, they are a chronic AFibber, this is their baseline rhythm, and they come in with AFib with RVR. They have AFib with a rapid ventricular rate. Technically, if they come in with a rate over 100, that's AFib with RVR. Please consider that the equivalent of sinus tach in a normal person. And look for the trigger. Look for the hypotension. Look for the GI bleed. Look for the sepsis. Look for the pain. Look for the thing that you would look for in a person who has sinus rhythm who's in sinus tach. Look for that in the AFib with RVR person who is in chronic AFib. Because that's what they do. That's their way of increasing their heart rate. This is a mistake I see made, particularly by novice people who are in the ER or just young people in medicine. We had a trauma case where somebody actually had an older person in chronic AFib, came in as a trauma patient with basically a ruptured either spleen or liver, I can't remember which solid organ, bleeding, and was therefore tachycardic, AFib with RVR on the monitor. And a young intern basically decided that the way to treat that was to treat the rate because, oh gosh, it's AFib with RVR, I've got to slow it down, and gave a beta blocker. Don't give a beta blocker to somebody who's bleeding to death. It's a horrific combination. That was the person's physiologic response to getting their heart rate up because they were in chronic AFib. It was the sinus tach equivalent. So don't just knee-jerk AFib with RVR, slow it down. Be more sophisticated with that. And often you may not need to slow it down. Rate control is something we do in new AFib or AFib there's no trigger for, but think about it, okay, be careful. That may be the sinus tach equivalent. And if somebody's been in AFib more than 48 hours, this is not somebody we would actually voluntarily cardiovert in the ER. There's a whole different talk on treating AFib in the ER, who gets rate, who gets rhythm, who gets cardioverted, et cetera, what to do. That's a gigantic category. We're not gonna talk about that here. The key here is to recognize that chronic AFib that's fast may have a reason to be fast that's just like a sinus tach in a healthy person with normal rhythms. And if somebody's unstable with AFib, go ahead and cardiovert regardless. Again, do a good physical exam, see if there's nothing you can fix other than that rhythm, but be careful with your AFib. Don't assume AFib with RVR has to get slowed down. Again, the treatment, physiologic response is what I mentioned here. And if you need to treat the rate, there's lots of ways to do this. No magic. Calcium channel blocker is fine, beta blocker is fine. There's no magic here. Amiodarone is fine. It's actually what they use primarily in Europe. Lots of things work for slowing down your rate. You can do that, and if you don't know what's what, so say you have that rate of 150 that's spot on, doesn't move, it's narrow, and it's regular. It's like, I don't know, is that flutter, fib? I don't know what that is. What is that? Is that sinus tach? You can do a carotid vagal maneuver and slow it down. It's kind of cool because you may bring out those it may slow down, increase the block of that sawtooth flutter. You'll bring out the sawtooth. It may be somebody where it converts them. If it's an SVT, it's a way we try to convert them. So it's something you can do that's a benign thing that may help you determine what these sort of narrow, complex, rapid rhythms are. Now, a couple of the things that are up in the atrium before we scooch down to the ventricles. Multifocal atrial tachycardia. This is basically several different foci in your atrium that say, I want to do it. No, I want to do it. No, me. No, me. No, I want to. No, me. The people that get that are people with chronic lung disease. We see that in COPDers. And what this is, the way you tell on an EKG that's what it is that if you look at the P waves, first of all, the rate will be a little bit irregular because each P wave's just a little bit different spot than the other. So the rate's a little bit irregular. That's one clue. And this is why all irregular narrow complex is not AFib. Look, because if you see P waves, but there are 3 different complexes of P waves, that's basically somebody with multifocal atrial tachycardia, MAT. This is not treated as a primary rhythm. You treat what causes this. So you go treat that COPD. You make that COPD better. Hypoxic, give them some oxygen. That's what tends to make them better when they have this rhythm. Here's a couple of sort of images to kind of compare and contrast. You can kind of take a look at as far as the EKGs with atrial rhythms. Now, the one we worry about the most is Wolff-Parkinson-White. This is that accessory pathway that we all know we should know something about it, and I can never remember exactly what it is I'm supposed to know, right? Shoot, I know that it causes fast things, and I know that people can go into cardiac arrest who have WPW. What your clue on an EKG that shows WPW is that they have a short PR. That PR is really tiny. Like the P wave is right in front of the QRS. There's no interval. Or you see a delta wave. It's actually slurring up into the QRS. Or your QRS is a little bit longer because it's actually blended into the QRS. Those are the signs for you that somebody has WPW. If they come in with WPW and they have a narrow, regular, complex rhythm, that's an SVT. So now it's at 160 and it's narrow. And I know they have WPW, but it's narrow. I can go ahead, it's going through the normal pathway to be narrow. It's not going through the accessory pathway. So I can go ahead and treat that like any other SVT. But if it's 160 and wide, I worry that it's going down this super fast pathway, that if I block anything in there, it's just gonna go faster and the patient's gonna degenerate. If you are not sure, again, don't worry. Take a step back. If they're stable, you don't have to do anything. And if you're really not sure if it's VT or SVT with a Barron-C or SVT through a WPW pathway, you're going to treat it like VTAC. And the treatment for that is procainamide. You're going to add procainamide to your bailiwick of things, your bag of tricks. Use procainamide. That's what you're going to use to treat this if you're unsure. If you have flutter, or excuse me, a fib with WPW, now there's no regular rhythm coming down there. It's just all this little jiggly bag of atrium that's sending down shocks irregularly through this super fast pathway. And your ventricle is like, whoa, what is happening? I'm going 300. No, now I'm going 180. Oh, no, now I'm going 220. Oh, no, now. And it's wide because it's going through this accessory pathway. Irregular with bursts of really fast rhythm and complexes that change in size. That is your, and this is not torsade. I'll show you a picture. That is your sign that this is AFib with WPW. That's a person that's procainamide. And actually, to be honest, If you wanted to just say, I don't even want to think about any of this, I just want to know in any wide complex tachycardia, regular or irregular, that I have one drug I can grab, technically you could grab procainamide as the only drug you use. It would be safe in all cases of a wide complex tachycardia. This is what it looks like, AFib going through a WPW pathway. Okay, these are, look at the amplitudes are kind of variable. It is really fast. It's 300 beats a minute in certain places in there. It's super fast. That needs to be treated with procainamide or shocking if they're unstable. This algorithm and this algorithm are beautiful from an article that we actually reviewed for the LLSA stuff a while back that are wonderful, wonderful algorithms for your reference. Let's go down to the ventricle. PVCs, you all have them, we all have them. They happen all the time. It's just your ventricle going, oh, I'm gonna have an extra beat. They're wide because they originate down in the ventricle. Most of the time they are no big deal. Okay, it's a premature beat that's below basically below the AV node. It's below this sort of thing. And you don't treat them. We used to treat them all the time. Don't treat them. You can hurt people by doing that. But when there are more of them, and they're from various places in the heart, especially somebody who's having ischemia or may have an electrolyte abnormality, we start to worry more. Multifocals still doesn't necessarily need anything done until it becomes a gang. So 3 or more in a row is technically VTAC. Sustained VTAC is when it just stays in that sort of wide complex rhythm. Non-sustained is bursts of these things, 3 beats, 12 beats, 20 beats, a minute of it, it goes away. These people, we know that VTAC is not normal. Your heart should not be doing VTAC. The key is how to tell the difference between VTAC and non-VTAC. The older the person, the sicker the person, the more heart disease that person has, the more likely that wide complex rhythm is VTAC. The younger the person, the healthier the person, the less likely, but it's not impossible. So again, you're going to default to being simple. Keep it simple, stupid. If it is unstable, you cardiovert. If it is stable, you have a chance to kind of take measure of what's what. VTAC is regular. So I'm going to see a regular wide complex tachycardia, and I'm going to go back and just look at their history, get a little more history from them, find out a little more. If I need to treat it, I can use lidocaine or amiodarone. Both are fine. I can even use procainamide. Those are fine. So, and if they basically lose their pulse completely, treat them as VFib. 2 last rhythms, and then we're going to call it a day. Torsade de Pointe. You hardly ever see torsade de Pointe anymore. We used to see it a lot back when people used tricyclic antidepressants commonly. We have so many other antidepressants now, we hardly ever see this. But torsade de Pointe is basically it's a VTAC rhythm, but it looks like, to me, it looks like those ribbons that you curl at a party. You know, they put up those little ribbons that you can make curl, like a DNA helix. It's bigger, littler, bigger, little, bigger, littler. That you treat with 2 things. Grab some bicarb if they're acidotic, use bicarb, and go ahead and give them MAG. These people usually are out. Okay, they're out. I'll tell you, cardioversion, or it's not cardioversion, it's actually defibrillation, doesn't really work in these people. So you're going to go ahead and use MAG and bicarbonate in those. And the last thing I'm going to mention is Brugada. So Brugada syndrome is something that didn't exist, at least wasn't named back when I trained, but it's been around. This is sudden death. This is the reason you're going to ask, we're going to talk about syncope later, you're going to ask about a history of sudden death in a family. You're going to ask about this. It's syncope or sudden death history, and these people basically come in, they're young, they're healthy, they're often Asian men, but can be anybody. And what you're going to do in these EKGs is you're going to look for look right to V1. V1's going to look like sort of a right bundle branch block pattern. It looks kind of weird. If it ever looks weird in V1, go to Google Brugada, push images, and see what's what. This is treated with an AICD. These people will actually can go on and have sudden death events. So this is treated with an AICD. So this is one of the things you need to know about. We'll talk about it in the syncope.